Welcome to this high-yield explainer of maternal and fetal physiology. Look, if you're an anesthesia resident, this is explicitly tailored to give you exactly what you need for those brutal board exams, and honestly, more importantly, for your clinical OB rotations. We're going to break down the absolutely critical physiological changes and pharmacological nuances you've got to master. Because remember, you're managing two patients at once here.
Here's our roadmap. We're going to map this complex clinical journey chronologically. So, 1. Maternal physiology. 2. Placental exchange. 3. Labor pharmacology. And wrapping up with 4. Fetal circulation. Let's get right into it.
Section 1. Maternal physiology. We have to start with mom, right? Because from the airway all the way down to the heart, pregnancy alters basically every physiological baseline we rely on. You simply cannot treat a parturient like a standard adult.
Okay, here is a massive high-yield point for your boards and your daily practice. The minimum alveolar concentration, or MAC, drops progressively during pregnancy. In fact, it hits a staggering 40% reduction at term. 40%! That goes for all general anesthetic agents. Why does this happen? Well, the pregnant body is just flooded with elevated progesterone, which acts kind of like a sedative, right alongside a massive surge in beta endorphins during labor. Bottom line, you need significantly lower doses of volatile anesthetics to keep your patient asleep.
And hey, it's not just general anesthetics either. Parturients also show this enhanced sensitivity to local anesthetics, meaning they require up to 30% less dose for regional blocks. We measure this using MLAC, the minimum local analgesic concentration. Basically, that's the concentration of a local anesthetic providing satisfactory analgesia in 50% of patients. Thanks to hormonal mediation and the engorgement of the epidural venous plexus, your standard epidural doses are going to go a lot further in a pregnant patient.
Moving up to the airway, guys, you're looking at a perfect storm for rapid desaturation. Oxygen consumption shoots up by 50%, while FRC, functional residual capacity, drops significantly because that enlarging uterus is just pushing the diaphragm right up. So, preoxygenation before induction? Absolutely strictly mandatory. Plus, those hormonal changes we talked about cause capillary engorgement, which literally leads to airway edema. You've got to anticipate this and always select a smaller ETT, typically a 6.0 or 6.5 millimeter. Oh, and one more thing. When you're ventilating, be incredibly careful. Extreme hypocapnia from hyperventilation will drastically reduce uterine blood flow, and that causes fetal hypoxemia. Just don't do it.
Now, the most dangerous moment for maternal heart strain, it might actually surprise you. You'd think the hardest work is over once the baby's actually out, right? But hemodynamically, the absolute greatest strain on the parturient's heart hits immediately after delivery. As the uterus contracts and involutes, it completely relieves that inferior vena cava compression, which violently spikes maternal cardiac output by up to 80% above third trimester values. The crucial takeaway here is that this sudden, massive autotransfusion drives up blood pressure and can actually precipitate acute heart failure. If you're managing a patient with pre-existing cardiac conditions like severe valvular disease or maybe pulmonary hypertension, this exact moment right after delivery is exactly when things can rapidly, and I mean rapidly, fall apart. Moving right along to Section 2, Placental Exchange. Let's transition away from maternal hemodynamics and look at the primary interface between our drugs and the baby, the placenta. While most volatile agents and IV induction drugs cross the placenta like it's not even there, you really need to know your exceptions. Here's a classic exam favorite that's also super relevant clinically. Chloroprocaine has the least placental transfer among local anesthetics. Why is that? Well, it's an ester local anesthetic, which means it gets rapidly metabolized by maternal plasma cholinesterase way before it even has a chance to cross over to the fetus.
Now, a truly fascinating and honestly dangerous phenomenon you'll encounter here is ion trapping. Remember, local anesthetics are weak bases. If a fetus becomes distressed and acidotic, its blood pH drops. So when the unionized local anesthetic crosses the placenta into that acidic fetal environment, it picks up a proton and becomes ionized. Because ionized molecules can't easily cross lipid membranes to get back out, the drug gets stuck. It's trapped right there in the fetal circulation. This means a distressed baby will actually pull and trap basic drugs across the placental barrier, which leads to dangerous drug accumulation and toxicity.
Okay, Section 3, Labor Pharmacology. Let's dive into how we actually pharmacologically manage the intense stress test of labor, delivery, and unfortunately postpartum hemorrhage.
When you're placing an epidural, residents and patients alike are always worried about slowing down the progression of labor. But
Good news. Using modern dilute combinations, like 0.125% bupivacaine mixed with 5 mics per mil of fentanyl, does not prolong labor. And it doesn't increase the risk of needing an operative delivery either. It just provides excellent analgesia while preserving the motor function the mother needs to push effectively. It's a real win-win.
Now, when epidurals cause sympathetic blockade, where the gravid uterus compresses the vena cava, you get supine hypotension syndrome. To treat this, phenylephrine is generally favored over traditional ephedrine in modern practice. You might think, wait, isn't phenylephrine a pure alpha agonist that constricts the uterine artery? Yes, it can cause some constriction, but clinical evidence shows it actually leads to less fetal acidosis compared to ephedrine. If the absolute worst happens and uterine atony occurs, leading to severe postpartum hemorrhage, you must instantly know your uterotonics and their absolute contraindications. There is no time to look this up. Methylargavanine, or methergine, causes intense uterine contractions, but it carries a risk of severe, stroke-level hypertension, so definitely avoid it in preeclamptic patients. On the flip side, carbaprost, or hemabate, is a synthetic prostaglandin that works absolute wonders for bleeding, but it can cause deadly bronchoconstriction. You absolutely never ever give hemabate to a patient with a history of asthma.
Here is another critical clinical point for your exams and the OR. If your patient is receiving a magnesium sulfate infusion, which, is standard for seizure prophylaxis and preeclampsia or for tocolysis, that magnesium is going to significantly enhance and prolong the effects of your non-depolarizing neuromuscular blockers during a general anesthetic. You absolutely have to dramatically reduce your paralytic dose and monitor those twitches vigilantly.
Let's bring it home with Section 4, Fetal Circulation. We're going to follow the flow of blood to understand the newborn's highly unique circulation and its complex transition to extrauterine life.
So in utero, the fetal lungs are essentially non-functional. They're filled with fluid and highly resistant to blood flow. Because of this, oxygenated blood returning from the placenta has to take a specific parallel path to bypass the lungs. It enters the inferior vena cava, hits the right atrium, and then the vast majority of this oxygen-rich blood shunts directly across the foramen ovale into the left atrium, where it's pumped out to supply the fetal brain and heart. That tiny bit of blood that actually makes it to the right ventricle, that gets shunted away from the lungs via the ductus arteriosus.
But at the exact moment of birth, everything changes. The baby takes its very first breath, lung expansion radically drops pulmonary vascular resistance, and pulmonary blood flow just surges. This massive pressure change causes the functional closure of the ductus arteriosus almost immediately. Following that, the anatomic closure of the ductus happens over the next 2 to 3 weeks. As for the foramen ovale, driven by increased left atrial pressure, it functionally closes at birth too, but it takes several months to completely seal up anatomically.
All right, let's quickly summarize your absolute high-yield facts for this explainer. Remember your 40% MAC reduction at term. Always use a left lateral tilt to prevent aortical cavocompression. Keep a close eye out for that massive 80% post-delivery cardiac output spike. Understand that fetal acidosis causes basic drug ion trapping. Know for sure that magnesium sulfate heavily enhances your paralytics. Always anticipate an edematous airway requiring a 6.0 to 6.5 ETT. And finally, avoid extreme hyperventilation because hypocapnia absolutely kills uterine blood flow.
But consider this final thought to leave you with. We just talked about the beautiful, seamless transition of fetal shunts closing at birth. But what happens if profound hypoxia or acidosis prevents those shunts from closing? The newborn plunges into a vicious, life-threatening cycle of persistent pulmonary hypertension, continuously shunting deoxygenated blood right back into systemic circulation. If you are the anesthesiologist in the room, how will you immediately manage that crisis to save the newborn's life? Think about it, review your neonatal resuscitation algorithms, and keep studying hard.